Hello, and thank you very much for the invitation. Today, I would like to talk about our experience of implementing the European Trauma Course in Ukraine during active war. This was not only about delivering courses, it was primarily about building interprofessional trauma team training and local teaching capacity, step by step, under, from our perspective, difficult circumstances. The program was started at the invitation of the Ukrainian Ministry of Health with the support from the World Health Organization. I will briefly explain the motivation for the program, how it was organized, how it changed over time, and what we learned. I do not need to mention that the war placed a very heavy burden on the Ukrainian healthcare system. The number of patients with major trauma increased several-fold. Compared to our Western European systems, the burden is round about 10 times as high. So modern trauma training wasn't optional, it became essential. What was needed was better trauma team function under pressure. In trauma care, outcomes depend not just on technical skills, but also on communication, task sharing, and rapid decision making, what we call the non-technical skills. From the ministry's perspective, the goal was to improve direct clinical care and to support a more interprofessional way of working, with stronger collaboration between professional groups. So the challenge was broader than delivering a course. It was about introducing a different way of training trauma teams in a system under strain. And that brings me to what the ETC actually is. The European Trauma Course, or ETC, is a simulation-based course for the early management of severely injured patients. It is designed around the reality that trauma care is delivered by teams, not by individual clinicians working alone. So the focus is not just on what one person does, but on how the team works together under pressure. The ETC combines technical skills and non-technical skills, such as communication, leadership, prioritization, and decision-making. It is also designed as an interprofessional course. That means that different professional groups learn together in the same scenarios, but with adaptive learning outcomes, reflecting how trauma care works in real practice. The ETC is mainly scenario-based, with practical workshops and structured debriefings, so participants learn by doing, working as a team and by reflecting. The question then was how to introduce this pretty advanced learning model into such a difficult setting. We decided early on that this program could not be introduced all at once. For many participants, team simulation was completely new. The same was true for non-technical skills teaching or for interprofessional learning, where different professional groups are trained together. The course also had to run bilingually, while teaching responsibility was gradually moving from international to Ukrainian faculty. So there were several layers of complexity at the same time. The phased model helped us manage educational, language, and organizational challenges while allowing local ownership to grow over time. In that sense, this was also about introducing a different educational culture, with more teamwork, structured communication, feedback, and debriefing. A gradual approach gave participants and faculty the time to adapt. So let me briefly show how all this was organized in practice. The program ran over 11 courses between May 24 and May 25, in 2 simulation centers, first in Ternopil and later in Kiev. All materials were translated into Ukrainian by the WHO. When needed, certified translators supported delivery. But as more Ukrainian faculty became involved, less translation was required. From the beginning, there was also a structured instructor pathway, so Ukrainian instructors could gradually take over, with the goal to make the program sustainable at national level. This point was very important. The aim was never only to deliver courses with outside support. The aim was to build a program that could increasingly be delivered by Ukrainian colleagues themselves. That is also why the 3 phases are important. Phase 1 took place in Ternopil. These courses were led by international faculty only, and they did not include trauma support practitioners yet. The main aim at this stage was to establish the course model in a manageable way. In Phase 2, during the first Kiev courses, one trauma support practitioner was added to each group. Also, Ukrainian faculty began to take more teaching responsibility. This allowed interprofessional team learning to begin while the course structure remained controlled. In Phase 3, the later Kiev courses, 2 trauma support practitioners were included in each group. This created a fuller interprofessional model. At the same time, most of the teaching was delivered by Ukrainian faculty, while international faculty moved into a more supportive role. So step by step, the training became both more interprofessional and more locally led. The gradual approach mattered. It allowed the course model to be established first, then adapted, and then handed over. By the end of this process, the program had reached a substantial scale. During the implementation, 11 courses had been delivered. In total, 328 participants were trained, of which were 264 medical candidates and 64 trauma support practitioners. So this was already a substantial training effort in a difficult environment. A Ukrainian instructor pathway was developed in parallel. 31 instructors achieved full certification. 52 were in training and another 40 had been identified for the pathway. This means that the program was not only producing trained participants, it was also creating the conditions for continuity because a local faculty base was being built at the same time. So what did the participants actually tell us about the program? We analyzed 321 evaluable feedback forms. The key message is that ratings stayed within a similar range across the whole program. In other words, the course remained well accepted across the 3 phases. The mean overall score was 3.92 in Phase 1, 3.83 in Phase 2, and 3.91 in Phase 3, on a 4-point Likert scale from poor to excellent. So as the course became more interprofessional and more locally led, there was no evident drop in perceived course quality. That was important because it suggested that localization and adaptation were possible without losing participant acceptance. Of course, these are educational evaluations, not clinical outcomes, but they still tell us whether the model was workable and credible in this setting. The qualitative feedback was also very consistent. The participants repeatedly said that the course was highly relevant to trauma care in Ukraine. They especially valued the focus on teamwork, communication, and leadership, areas that many felt had received too little attention in earlier training. Non-technical skills were among the most valued parts of the course. Closed-loop communication and the stop procedure were mentioned many times, not as theory, but as practical tools for daily clinical work. As trauma support practitioners became more fully integrated, participants felt the scenarios were more realistic and closer to real trauma team function. That is important because realism is one of the things that makes simulation-based training credible. The later multiple casualty scenarios were especially well received because they reflected the reality many participants were facing. At the same time, participants also asked for more conflict-related content, more technical depth in some areas, and more help with applying these principles in their own hospitals. So the feedback was positive, but also very useful for further development. And that brings me to the main lessons we took from this work. One key lesson was that interprofessional trauma team training can be introduced and adapted even during active war. The phased model helped us deal with educational, language and organizational challenges, while the course became increasingly locally led. Without that stepwise approach, the complexity might simply have been too great. A second lesson was that the transition to Ukrainian faculty was possible. This was not just about running courses, it was also about building local capacity and national ownership. We must also not forget that WHO support was crucial to get this off the ground. It helped create the conditions for implementation, adaptation, and continuity under difficult circumstances. So in the end, it was not only about training people, it was also about building a different way of working. And finally, what does this mean for the future? Looking ahead, I think there are several priorities now. First, further scale up in Ukraine, building on the local faculty base that now exists. Second, further adaptation of the course content, especially in relation to conflict-related injuries and multiple casualty management, because this was clearly requested by the participants. Third, we need to address the implementation gap. People may value the course and learn from it, but applying these principles in their own hospitals is not always easy. Local systems, limited resources, and traditional ways of working can make this very difficult. So future work should not only train individuals, but also help teams and institutions put these ideas into practice. Finally, I think it is also really important to say that this is not a one-way process. The European trauma community is also learning from Ukraine. We very much look forward to continued clinical input from our Ukrainian colleagues, because their experience under the current conditions can help improve trauma training and trauma systems more widely, including our own. I've reached the end of my talk, and I thank you very much for your attention. Slava Ukraini!